Kia ora e te whānau. Thank you for joining us this evening. It's great to have you here for what we know will be an insightful and invaluable session. Valuable session. My name is Kate and I'm the support coordinator for Fertility New Zealand. We're a national charity dedicated to providing support and information services and advocating for all people facing fertility challenges. Whether you're just beginning to think about your fertility, undergoing treatment, or exploring alternative pathways to parenthood, Fertility New Zealand is here to support you with trustworthy information, community, and care. As a charity, we rely on the generosity of our community to make resources like tonight's webinar possible. If you find value in what we offer, please consider making a donation. So you can do this via this link or through our website at fertilitynz.org.nz. Every contribution helps us make our mission and reach more possible if you need support. Tonight's topic is treatment add-ons, and we're very fortunate to be joined by Dr. Andrew Murray, Group Medical Director and Fertility Specialist at Fertility Associates in Wellington. Andrew is a recognised leader in the field, known for both his deep clinical expertise and compassionate approach. In this webinar, Andrew will talk through what treatment add-ons are, when they may be needed, and what you should consider when you're deciding whether they're right for you. We'll finish up with a live Q&A session, so please feel free to type in your questions into the chat at any time, and we'll aim to get through as many as we can at the end. Thank you again for joining us. We're so glad you're here. And now I'm very pleased to hand over to Dr. Andrew Murray.
Hi, well, good evening, everybody, and thanks for the privilege of being able to present to you all tonight about IVF add-ons. It's a subject that's dear to my heart because over the years there's been a number of things that have come and gone, and there's an element of things. It's a bit like fashion, I guess. Some things are currently the flavour of the month, and then they fade away. Things come and go, and so it's something that we're often thinking about as well as clinicians, of course. And so the plan tonight is to try and provide you with a really balanced view on what the place for add-on treatments is. So I'll just go through a brief slide explaining my disclosures. So this is the one before. So yeah, my main role at the moment is Chief Medical Officer of Fertility Associates. So I'm still very busy clinically, but we also run a number of clinics in Asia now. So I'm up there a fair bit of the time, helping our colleagues there as well, not so much clinically, but providing advice and management expertise, given my fertility experience. So that's an exciting development for us. Coming back to add-ons. Now, what exactly are add-ons? Well, they're sometimes known as adjuncts. They're basically optional treatment steps on top of the standard fertility treatments that are there. So they are not necessarily essential. If they were, we would make them as part of the standard part of treatment. But these are things that possibly, and that's the operative word, possibly may help some people have a better chance of a baby. Some of them, as we'll go on to see, maybe don't. And so I think it's important that we present that balanced view. Now, in the time we have, it is literally impossible to go through every single add-on that is potentially available. This list here is by no means exhaustive, and far from my intention tonight to go through every single add-on. I've just selected a few of the more common ones. But as you can see here, there's a pretty long laundry list of potential things. Now, don't go screenshotting this and asking your specialist for all of these things tomorrow. Please don't do that. But I just wanted to present you, the vast wealth of things that are out there, and no doubt will increase in number over time. Okay, so what do we have to consider as your specialists? It's certainly something that we are often asked about, and I'm just presenting a really honest appraisal of that here. I mean, often we're asked about add-ons, not because we've come up with the idea, but a patient's gone to a webinar or done some Googling, or perhaps talked to other patients, and patients become aware of certain add-ons from those channels. There is an element of, well, hey, if we don't offer it, maybe the patient will go to another clinic who does. And so we have to be cognizant of that. There is always that pressure, and I'm going to have a few more words on this, but if someone comes through, they go through their first IVF cycle, they haven't had a pregnancy as a result, there is that pressure, well, hey, doc, there must have been something not right, therefore we need to do something different. But one thing I do think there is a place for when it comes to add-ons is that, irrespective of whether they are improving the chance of a baby or not, if they are improving your ability to stay in treatment and not exit treatment, because on some level you have a sense, well, we are trying something different, we are doing something extra. If that actually keeps you going, that is probably the most important thing anyone can do, is to keep going. And I'll show you some more data around that shortly. A really key thing about anything that we provide, particularly in the add-on space, is that it does no harm. It's all very well to say, okay, maybe this treatment might not do any good, but it's also equally important to know that it doesn't do any harm. And so there needs to have been some studies to prove that. And finally, of course, we need to think about cost. I mean, many of these add-ons are certainly not cheap. And so if we're going to ask anyone to have some sort of additional measure in addition to the treatment they're already oftentimes paying a lot of money for, we need to be very clear that there is a benefit for that. And so this is the sort of balancing act we've got between cost, effectiveness of the treatment, and of course, how unpleasant some of these add-ons might actually be as well. This slide here, I've started to speak a lot to across all of the clinics that I'm involved with, both here in New Zealand and up in Asia. And I think it's really, really important principles for both our staff who look after you and yourselves as patients who are accessing care to understand these concepts. And what I mean by that is that we need to provide an environment where you have both persistence and the strength to keep going, because I know this is not an easy thing to go through. And that all starts at the very beginning with setting the right scene, making sure that before you start your first IVF cycle, you understand exactly what is involved. What are the success rates? How likely is it that you will end up with a baby? And importantly, that treatment may mean more than one cycle. So much pressure is put on us as patients and as providers to say we must succeed from this single attempt. By being able to give you the important information, whether it's written, video, timeframes, how long will it take, what is your access to funding if possible, appropriate support from the nurses and the counsellors, that allows you to actually forecast ahead and prepare. And there's lots of studies that show that patients that understand all of this at the front end of treatment do so much better, not only in terms of pregnancy rates, but also just in their experience. And that really matters a lot. And finally, this is all working towards what we call the resilience mindset, where you understand at the very beginning the importance of persistence. And to have that, you've got to have absolute trust in the team looking after you and the ability to keep going when you feel ready. And of course, circling back to your clinical team as and when is appropriate. If we just take an example of 100 couples where, and I realize not everyone's a couple, this is not necessarily exclusive to straight people, but if we took 100 cycles of IVF where the female was a 35-year-old woman, so out of those original 100 patients, 40 of them on average will end up with a baby from that first IVF cycle. So that means there's still 60 couples or 60 women who have not yet had a baby who will potentially need to try again. Out of that 60, another 24 will have a baby as a result of that treatment. So we've now got 64 out of the initial 100 who are going to go on to have a baby. And if we repeat the same exercise again a third time, the remaining 36 people who have not yet had a baby or going to try for a third time. What this shows is that over the course of those 3 cycles, roughly half of the people needed to do 2 or 3 to end up with a baby. So my point of showing you all this is just to really highlight the fact that persistence is so important. Giving up at the first hurdle it doesn't necessarily mean, hey, if you're not in this 40%, that we need to start looking for an add-on, or that we need to be doing something different or choosing a different drug or whatever. It might just be that the most important thing anyone can do is just to do another cycle if they can. All right. So, yeah. Now, coming back to the add-on side of things, the magnifying glass is very much on providers of IVF, and there's been plenty of examples of media highlights. This is from the UK, this particular headline. There's certainly been some scrutiny of add-on treatments both across the ditch in Australia and here in New Zealand. And so we have to be, I suppose, scrupulous in providing evidence-based care. If we're going to say to you, look, yes, we agree to this add-on, we have to back that up by the knowledge that there is actually evidence for its benefit, particularly if you're paying money for it as well. So tonight what I'm going to do is just give you a bit of a brief overview of some of the key add-ons, not all of them. There will be some time for questions at the end, so things that I might not have covered tonight, I'm happy to answer if I can. Some brief experience of some of the add-ons at FA where I work, and I'll just finish with some concluding thoughts before we head to Q&A. So in terms of the sources for where I've provided this information tonight, it hasn't all just come out of my head or my own personal experience. There are actually some really great, thorough review articles out there, and I do not expect you to go to the scientific literature and read them. This review here, for example, that's about 70 pages long. This one's about 40. Fortunately for you all, I have read them all. So I've distilled some of the edited highlights for tonight's talk and some of the other talks I've given in the past. So just for ease, I'm going to present the conclusions about add-ons in a sort of like a traffic light system, very similar to the Human Fertilisation and Embryology Authority does this in the UK. And I think it's a really great way of communicating whether things are beneficial or otherwise. So if it's a green light, it means, yep, this is a good thing to do. There's evidence that it may well be beneficial, so we should have no hesitation offering it. The amber light is more for add-ons that we think, well, for some people they might be helpful, others not so much. If we added it on for everyone, it might make a difference for some patients, but for others it will make absolutely no difference. Now, an amber add-on is not necessarily a bad thing. Going back to my persistence and treatment philosophy, but we have to be very open with our patients that, hey, this might be helpful, but we know it doesn't do any harm, so therefore let's give it a go. And then finally, the important ones to avoid is anything that perhaps initially was thought to be useful, but then subsequently in further studies was shown not to be. Okay, so on we go. So let's start with something that I'm sure many who are viewing this tonight will have heard of or possibly even have had, and that's hysteroscopy. So using a camera to look inside the womb, to look for problems inside the uterus that could affect the embryo's chance of implanting. Now, with regards to hysteroscopy's place in fertility medicine, traditionally it's usually been reserved for when we find a problem and then need to deal with it. So say a polyp, or we suspect adhesions or possibly even a fibroid if it's indenting into the cavity. It's sometimes also used as a tool if you've had a difficult embryo transfer. But there was a trend for a while there to say, hey, we should do hysteroscopy on absolutely everybody before they even start their treatment. Well, what does the evidence tell us? Well, the way, and I'm sorry, this slide looks really busy. Don't worry, you don't have to drill down on it too much. But when you present detailed studies in science and in medicine, they do what we call a meta-analysis. So very brief overview. Essentially, anything that crosses this middle line, if the studies overlap that, it means that there is unlikely to be any difference either way. Whereas if something's clearly beneficial, the majority of the studies will be to the right of the line, and if it's not beneficial, it will be to the left. So in terms of what we call the meta-analysis, where they've pulled all of the results of all of the high-quality studies looking at screening hysteroscopy, this first box is for unselected patients. Basically, anyone that's rocking up having IVF, whether it's their first go, their third go, or it was unspecified, there was no benefit either way, because you see the studies, the results cross this magical line here. With regards to patients undergoing their very first IVF cycle, there was potentially a trend towards benefit. You'll see this study thought there was, this study wasn't so convincing. So when you combine those two, it still crosses one. Now I know that's only just crossing, but it still means that these results could have been by chance. But when you look at patients who have had 2 or more unsuccessful treatments, and there were quite a few more studies in that, the majority of them did show a benefit for hysteroscopy. And so we can see that in this third group of patients. So the conclusion from all of that is that overall, there's really no benefit for performing routine hysteroscopy for all women undergoing IVF, but it might benefit a select group, particularly if you've had 1 or more unsuccessful attempts, or particularly a history of difficult embryo transfer, if the cervix is particularly tight or angled in a particularly challenging way. And by and large, I would say that's how the majority of fertility specialists are approaching this. Another add-on that has received a massive amount of attention over the last decade is something called the endometrial receptivity array, or the ERA. And this, when it first came out, it really sounded quite sexy and really, really useful, because, in front of you, you've got a patient, she's had 3 or 4 transfers, you've done a bunch of other blood tests looking for autoimmune problems perhaps, you've done the hysteroscopy, all that seems fine. Then we've got the ERA. And so the idea behind it is, I'm sure many of you have heard about the implantation window. Essentially, there is evidence that the embryo and the endometrium, the lining of the womb, need to be closely synchronized for them to effectively talk to each other. And that's largely around how many days of progesterone, whether you've ovulated and made your own progesterone, or we've provided the progesterone artificially through treatment. For the majority of patients, after 5 completed days or 120 hours, the implantation window is open. But the theory behind ERA was that maybe some women have either a pre-receptive or post-receptive endometrium, and perhaps they should be having their transfers a day earlier or a day later. And this was based on some of the genes that were being expressed in the lining of the uterus. Now, the only way to determine that was, of course, to take a tissue sample, not in a month that you're going to put the embryo back, that would kind of stuff the lining up, but they showed that this gene expression profile seemed to be stable month to month to month. So there was a lot of fervor for this particular tool. I've done quite a few myself. But what does the evidence now, we're 10 years on, and we've now got much more data to see whether there was any benefit. So basically, the news isn't so good for ERA. several small, what we call retrospective studies in good prognosis patients, egg donation cycles. RIF stands for recurrent implantation failure. There were at least 3 studies there. They all looked at the role of ERA, and they really couldn't find any benefit. Retrospective studies aren't quite so good. That means you're looking back over time. What is the gold standard is you take a group of patients and you do what we call a randomized controlled trial, where you say, yes, you have the treatment, or you have ideally a placebo, and neither group knows which they're having. And we've got 2 quite large studies that have done this. This one by Doyle from 3 years ago, over 30 different IVF sites, nearly 800 women. And they also did genetic testing of the embryo, so what we call euploid, that's a normal chromosome embryo, was going back. And basically, the live birth rate, you'll see here 58.5 versus 61.9%. And that's statistically not a different number. That's essentially saying, basically it's 60% in both groups. So they didn't find a benefit. In one of the other larger studies, this time with over 5,000 patients, either using their own eggs or in some of the patients donated eggs, they couldn't demonstrate a better outcome when they'd done this personalized embryo transfer based on the ERA result. And in fact, in that particular study, they found that the live birth rate and the cumulative live birth rate was actually lower after doing an ERA and doing a fresh transfer. So it's interesting. I think this is a good example of how something, it makes good scientific sense. It's something that seems like it would make a difference. But the importance is you have to look at a large number of patients over time to really know the truth. And so this now, in most parts of the world, gets the red traffic light. I think many centres would no longer offer ERA. I mentioned at the beginning of my talk endometrial, things that were a bit sort of in fashion. The next one that I just want to present was quite popular about 5 to 8 years ago, called endometrial scratch. The idea here was that the month before you put the embryo back, you put something called a propel inside the uterus and you give the lining a bit of a scratch around, the idea being it somehow freshens things up. I even heard one, I think this was in the US, they talked about endometrial exfoliation, kind of making it sound like some sort of beauty treatment. Any woman that's ever had this will know that's not really the way you'd experience it. We participated in one of the largest trials, and this was actually spearheaded by a New Zealander, Professor Sarah Lenson, who's now working in Australia, but obviously we hope she comes back to New Zealand one day. And in Sarah's study, they had, I think it was well over 800 patients, and they found no significant difference in live birth rates between the control group and endometrial scratching. So this is certainly probably doesn't make any difference either way, and so this is no longer a popular option. Certainly not something we would recommend. Embryo glue. Now, this is currently offered. Embryo glue is not actually glue. We don't have the embryologist dab a little bit of super glue on the embryo before the transfer, but embryo glue is actually, it's hyaluronic acid in a particular concentration, and the idea is that it assists the embryo interact with the endometrium of the woman's uterus. And so there is some low quality evidence that adding embryo glue may decrease miscarriage rates, and moderate quality evidence that it might even improve live birth rates. And so certainly in all of the clinics that I'm involved with, and I'd say most clinics in New Zealand, embryo glue is standard of care now. And so it's not really an add-on anymore, though strictly speaking, it's still seen as such. But we certainly don't charge an additional fee for it at Fertility Associates. It's a standard of care now. I think an exciting area in this whole thing, and it's a shame, unfortunately, with this platform, I can't show you the video. Everything's static slides, but we now have incubators with tiny little cameras taking a photo every 10 minutes, and that can then be put together as a time-lapse image to look for more detail, essentially, of what the embryos are doing in order to help us select who is the best embryo. So there are certain milestones that things should happen. For example, if we looked at an embryo that went from a single egg to 2, then 4, then 8 cells and so on, if we compared that embryo to one that perhaps went from a single cell straight to 3 cells and then carried on dividing, you would never have seen that without time-lapse, but studies are very clear now that the second thing I described, the 1 to 3 embryo, that will have a much lower implantation rate and live birth rate than the first situation I described. The other really neat thing about the time-lapse incubators is that it allows our embryologists to look after your embryos and observe them without having to take them out of the incubator and put them under the microscope. So you're not getting the disturbance in temperature or the gas changes. Everything's undisturbed for those 3 to 5, 6 days. And I am sure that in time that will become the standard of care. Where the exciting part comes in, and there's still ongoing work, is of course we can point AI at the videos that these machines are creating, and the AI algorithms are basically looking for things that we wouldn't have otherwise noticed. And over time there are various platforms that come up with a score. The latest one we use is called the IDA score, and essentially it helps us rank which embryos we would put back first. Importantly, it's not a diagnostic thing, it's not looking at the chromosomes, but it is basically getting extra information from a very capable incubator that really looks after your embryo as well. So the other advantage is that it means that the embryologists can essentially go back in time to look for when things happen, as opposed to being time pressured that they must get the embryos out of the incubator at a particular time. So yeah, it's still in the amber category, not absolutely necessary to have time lapse, but as someone that is heavily involved in running IVF clinics, I think time lapse incubators are fantastic, and they certainly have a number of advantages for workflow, and the information that they provide us certainly is helpful when it comes to picking which embryos we would select to go back first. I just want to introduce a concept that I'm sure many of you have heard of called aneuploidy. So aneuploidy is a fancy medical way of describing abnormal chromosome number. It's well known that as women get older, fertility rates decline, and that's not so much due to the decrease in the number of eggs, but rather of all of the eggs that are still there, many of them lose the competency to arrange the chromosomes properly, particularly at the time of ovulation, or in the case of IVF, just before we're going to collect them. And so as you can see on this green line here on this graph, the rate of aneuploidy goes up quite significantly, particularly over the age of 38, and certainly well into the 40s. And so basically what this is showing is the rate of abnormalities in the eggs of women. And so, for example, if you're 43, 60% of your eggs will unfortunately have chromosome abnormalities. And so correspondingly, the miscarriage rate goes up. And that's basically nature doing its job, because it's recognized, hey, this isn't right, this embryo that's got abnormal chromosomes. Unfortunately, miscarriages most often, not always of course, due to nature recognizing that there is an abnormal chromosome makeup, and correspondingly the birth rate goes down. So we now have the ability to test embryos by taking a small number of the cells away from the part that makes the baby, but down here from what's called the trophectoderm, and analyzing those cells for the chromosomes. And so whilst testing the embryos can't change what they actually are, they are what they are, it may shorten the time to pregnancy because you would rule out those ones that have abnormal chromosomes. And so particularly for women 38 and older, there's a number of studies now that have shown that it shortens the time to pregnancy. And it has been shown in some studies that particularly in older patients, 38 and older and well into the 40s, it may actually be really cost effective by not having multiple embryo transfers of embryos that you don't know the chromosome status of. You could be paying for frozen embryo transfers that are unfortunately never going to work. And so by drilling down towards only those embryos that are chromosomally normal, it can be a very cost-effective strategy. We've recently put together a program called Family Builder that recognises this, and this is basically around accumulating a cohort of embryos in order to improve your odds of achieving your total goal. And again, this is buying into that concept of not just putting all the pressure on one single cycle, but looking at a series of cycles over time to accumulate embryos that we do the chromosome testing for, to essentially improve your chances of achieving the total family size that you want, whether that's one child, two children, or otherwise. Next add-on, androgens. So androgens are the male hormones. All women produce some androgens. That's normal. In fact, to make estrogen, you need testosterone. Testosterone is actually converted to estrogen. Well, a while back, there were some investigators that looked into the idea that, well, hey, if you provide more fuel for the fire, give women some androgens before they start treatment, particularly women with low egg reserves, maybe you'll help their ovaries perform better. And so the idea is that it upregulates the receptors on the ovary to respond better to the drugs, provides a precursor for the estrogen that's necessary. Maybe we get more eggs by doing this. What do the studies show? Well, the most recent review of this was actually conducted by 3 of our own FA doctors. So Sandeep is one of our newest docs in Wellington, about to become a CREI. Simon McDowell, who is the medical director in Wellington, and another Wellington boy, Sam Lapine, who's now one of our main clinicians in Tauranga. These 3 gentlemen did a meta-analysis for the Cochrane Review, along with some others, and looked at 2 of the key and most popular androgens, DHEA and testosterone. And rather than wade through everything in massive detail, if we just look at DHEA, going back to this forest plot that I showed you before, long story short, DHEA, because everything's crossing 1, it does not make any difference. And so we're not routinely offering that to anyone. That's probably makes no difference, unlikely to do any harm. The other hassle with DHEA is you need to take it for at least 2, sometimes 3 months. And this is in a group of patients who often don't really want to spend that amount of time prepping for their next IVF cycle. Testosterone, on the other hand, does seem to be a little more promising. Some of the studies were a bit ambivalent, but when you pull all of them together the results do fall on the side of favouring treatment. And so this number here, called an odds ratio, is basically saying if you take testosterone and you're in this group of patients, you are 2.5 times more likely to have a live birth than if you don't. And so we're working off a relatively low baseline. It's important to understand that. But essentially what they're saying is, well, in this group of patients who are poor responders and might not do so well, the live birth rate was about 10%. When they took testosterone, depending on which study you read, it increased to between 15 and 30%. So this has become a standard of care for our patients who are potentially going to be poor responders. These are women with the low AMH who have done IVF with low egg numbers. We are often putting them on a protocol that uses DHEA. Testosterone, not DHEA. HCG infusion. So HCG infusion is where you place a small amount of pregnancy hormone inside the uterus, a few minutes, usually 5 to 10 minutes at the most, before you put the embryo back. Now, there was a lot of fervour around this. There was a Cochrane review done back in 2018, and the numbers looked really promising, and so this was something that a lot of clinics jumped on board with. But a really important thing to remember with critiquing studies is the devil is in the detail. Many of the studies in this Cochrane review were putting back what we call cleavage stage embryos or day 3 embryos, whereas most clinics now, when they can, are waiting till day 5. And so when you pulled out the studies that only included day 5 transfers, there actually didn't seem to be such a difference. This has been done subsequently. So I'll just show you a couple of further papers. So a lot of this work's actually come out of China. They have large clinics with large numbers of patients. They showed in their own subsequent meta-analysis, if it was only done in fresh cycles, no benefit. Possibly if you've had more than 2 failed cycles, maybe. There was a third study that looked at, meta-analysis that looked at 15 randomized studies, and it looked a bit more promising there. So the sort of net result of all of this was 50% versus 33. So that was the HCG group. This was not. But importantly, none of these studies broke down whether they were day 3 or day 5 embryos. In the subsequent study in 2019, where they did look at that difference, there was no difference essentially. Our own experience, and I realize this is a little bit complicated, but basically what this is showing along the bottom here, this was some work that was actually done by a medical student that did a summer an elective program with me. And I got her to look back at all of the patients that had up to 13 transfers and whether we'd given HCG or not given HCG. And this is the pregnancy outcome up the side. So the blue lines are the patients who had HCG, and the green ones were the patients that didn't. And basically what you can see from this is that, well, number one, going back to my persistence mantra, people all the way out to embryo transfer 13 were still getting pregnancies. In fact, there was a bit of an uplift there. But importantly, there were far more pregnancies in the group not getting HCG than the ones that were. Now, this is not a scientific study, it's just a retrospective analysis. But based on these results, we couldn't hand on heart say, hey, we think this thing's actually really making a difference. Now, of course, for the patients that did get a baby from having HCG infusions, and if they come back to see us, they're not going to say, hey, don't do that HCG thing. Of course, we'll still do it because the last thing we did for them, including that, seemed to work. So it's hard to take that away. It certainly doesn't seem to do any harm. But based on our experience, we're no longer offering this as a routine thing. If someone insists on having it, we're okay with it. But I think it's really important to emphasize that the majority of studies looking at day 5 embryo transfers, they're showing that it probably doesn't. If you've had a baby before with this technique, no problem, we'll do it again. But as I say, there's not a clear-cut benefit from the literature. I think we're nearly there. Yeah, so this is just showing that we were sort of nonplussed about it, but we're not offering it routinely now. Okay, well, I like this particular graph. It's called the Gartner height curve. So I think this is true for so many of the add-ons where someone comes up with a fantastic idea and we all jump on board, and expectations are high and we're all going, this is amazing, let's keep going, let's do this. And then we start to see reality hit where it doesn't seem to be working for everyone. And then over time, things kind of balance out. We work out perhaps who things are beneficial for, who things are not. And you kind of reach this, what we call plateau of productivity, where essentially we figure out who things are best for. Well, look, those are some of the main add-ons. As I said before, I'm more than happy to answer other questions. But before finishing up on this part of the talk, I just want to come back to that first slide. I think these are really relevant points when thinking about the topic of add-ons. We really have to think as clinicians, are we really doing this just because of fear of competition? But importantly, and I really feel passionately about this, as long as add-ons are not ridiculously expensive, they're not doing harm, they're not invasive, if their only benefit is to keep you in treatment, to provide that resilience and strength to keep going, the most important add-on you can ever do, in my view, is the next cycle. You know, keeping going is just so key. Of course, anything we offer has to do no harm, and we have to be very mindful of cost. But sometimes we also have to be brave enough to stop providing those add-ons, particularly in the face of evidence that maybe they aren't so helpful. And as I said earlier, we need to be very transparent, particularly if there are fees being charged for these things. We need to be very transparent about the benefit. So I'm hoping I've come across as very transparent tonight. I'm more than happy to answer any questions. If I can leave you with one key message, it's come to your clinic appointments with this mindset in place, that you've got to understand what's ahead, get the information you need so you can forecast and prepare for the future, get the resources you require, and build that resilience mindset, because that is going to be what gets you across the line. All right, team, thanks very much. I'm going to hand over for the Q&A. All right.
That was lovely. There's a question here there. Can you see that question?
I can. So yeah, just so so there's a question that's what are the current thoughts on intralipids around embryo transfer? So intralipids, for those that don't know, is basically the idea behind intralipids is it's an infusion of fatty acids. Basically, it's a thought to have anti-inflammatory and antioxidant properties. The idea being that it somehow dampens down one's immune system to make it a little less aggressive towards the embryo. I haven't presented the data on intralipids, but it's definitely there, and the data does not support the use of intralipids at all. In fact, the data is really sketchy. Intralipids are not, they're not cheap. I think some clinics charge $700-800. You have to sit there for 3 or 4 hours. You have to have multiple doses, and I certainly am not someone that recommends them because the evidence is just not there. Is there a website for patients with trusted information about IVF optional extras? Absolutely. So certainly in New Zealand, if you go to any of the local providers, they will describe some of the add-ons and have descriptions. But if you want something that's completely non-clinic related, because understandably you say, well, hey, that's the providers. There's a really good website run by the HFEA, the Human Fertilization Embryology Authority. So if you just Googled HFEA and traffic light, that has a fantastic resource there with just about every add-on you can think of, and it'll show you what the evidence suggests. So if anyone wants to have a look at a good resource, that would be one I would recommend. Just refreshing to see if there's any other questions.
Yeah, thank you for such an insightful webinar as well. Very informative and lots of information there. So thank you for that. Just putting it out to the group. Any final questions before we wrap up for the evening? So just a couple of waiting there a couple of seconds there.
Oh, someone's typing.
Oh, fantastic. And just out of curiosity there, Andrew, how can people advocate for themselves during the fertility process, especially when they're offered multiple options?
Yeah, I get it. It's really hard, and believe me, as someone, when we see patients, particularly if it's their first appointment, you've got half an hour to meet someone, establish a rapport, get their history, go through their existing results, maybe do an ultrasound scan, come up with a management plan, and then perhaps explain what that's involving. There is a lot, and there's just getting more and more and more. So it's, I don't think, realistic to try and expect anyone to absorb all of that in a half-hour appointment when it's often, such a foreign language and a foreign concept, let alone such a sensitive issue that there's such a huge amount of trust that you're handing over to the provider. So to look back to your question, I think the key thing is to not be in a rush to try and understand everything all at once. Most providers of fertility services are doing that in such a way that it's a team effort, it's teamwork. It's not all about your doctor. And although you'll have a lot of interaction with the nursing staff as well, the nursing staff come from a team. But basically, you've got a team of people there who want the best for you, and I think that's true from any fertility service that I've ever had anything to do with. I think you just need to take the time you need to gather the information. Now, some people, that's in written information, and most clinics provide written collateral around the various treatment options. You certainly should clearly understand what things will cost or whether you're eligible for public funding. That's something that you shouldn't leave an appointment not understanding. Secondly, certainly in our own clinics, we've developed some really amazing videos all about IVF and the various steps that are involved, and they go as far as you kind of can't move to the next stage until you've answered the questions about the one before. So they check that you understand what's involved, and we can actually, our nursing team can see where you're getting to in those videos, and if someone's stuck on a particular stage, we can actually reach out and say, hey, we see you're stuck on this part of the video. Is there something else you need to know? But most importantly, don't be afraid to ask. People involved in this area of medicine, we want you to have a good experience. We want you to succeed, but most importantly, we want you to have a good experience during this.
Thank you, Andrew.
So there's a question there. What questions should patients ask their clinic before agreeing to an add-on? I think the key one to ask is, what is the evidence this will be helpful? And that doesn't necessarily mean a detailed presentation like this with all of the studies, but the clinician should be able to say to you, well, based on the majority of research, it falls on, yes, it's going to be beneficial, or it may be beneficial, or perhaps it might be harmful. You definitely want to ask efficacy, so whether it's effective. Secondly, you need to understand what it might cost, and that might mean for some add-on treatments, it's not just a one-off cost, there might be recurring things. The intralipid example was one before. And then finally, what is actually involved in the treatment? This endometrial scratch as an example, that makes it sound quite benign, but that involves speculum in the vagina, a rigid, semi-rigid tube going right through the cervix into the uterus and being scratched around. not the most pleasant of experience. So, look, I know many fertility patients, if we told you to stand on your head for 10 minutes a day, rubbing your tummy and doing something else, you would do it if you thought that your clinician genuinely believed it was going to help you. But yeah, you've got to understand what's actually involved with the add-on as well. So to recap, yeah, effectiveness, cost, and what's actually involved. How invasive is it?
Thank you for that, Andrew. That's very helpful and insightful, so thank you. Huge thank you to you, Dr. Andrew Murray, for your generosity, for sharing your time and expertise with us tonight. We hope you found this webinar informative and helpful as you navigate your own fertility journey. We hope you found the session informative and reassuring wherever you are on your journey as well. If you'd like to revisit tonight's webinar, share it with someone else. The recording will be uploaded to our website later this week at fertilitynz.org.nz. As always, Fertility New Zealand is here for you. If you have any questions that come up after tonight's session, or if you'd like support at any stage on your journey, please don't hesitate to get in touch. You can reach out to our helpline by emailing info@fertilitynz.org.nz. We're here to help, and you don't have to face this journey alone. As a charitable organisation, we rely on your generosity of our community. If you're in a position to give, please make a donation to support our ongoing mahi. Your contribution allows us to continue providing free information and support to people throughout Aotearoa. Thank you again for being here tonight. Take care, and we hope to see you again soon. Thank you, Andrew. Good night, everybody.
You're welcome. Good luck, everyone. Thanks. Bye-bye.